Okay, your ETA is 5 minutes with the GSW to the chest. Base out.
Help! I need help here.
Who's this patient?
John is a 32-year-old male, gunshot wound to the left
In
chest.
here. Get the attending and get the trauma team.
What have we got?
We have a 32-year-old male, gunshot to the chest, BP 100/60, pulse 112, respiration 28.
Are we ready to move him?
He's awake and alert. 2 peripheral IVs in. 1, 2, 3.
Wait a minute.
Lactated ringers hanging, no meds given.
What's your name?
John Mason.
Airway's clear.
Let me monitor him.
Brazil 2 connection.
Brazil 2.
Stop
Scissoring him, I need to listen here. Let's get an x-ray down here. We have decreased breath sounds on the left side. I need a chest tube set up.
BP's 120/76.
I'd appreciate some heads up on trauma. What do we got here?
With a 32-year-old male with a gunshot wound to the left chest. Mid-clavicular, second intercostal space. BP in the field is 110/60. On arrival, 120/76. No ACP noted. Pulse is 137. X-ray is on its way down. We have decreased breath sounds on the left side. Where's that chest tube?
Chest tube.
I'll do it.
He's losing his vitals. Pressure's 80.
I need an ET tube
Okay, let's get some
now.
blood in this guy.
7.5 tube.
Let's get 4 units.
Hello?
His pressure's 60. He's crashing.
Give me the
We have blood
thoracotomy
coming
tray.
down. We need 4 units of blood. I got it.
Has he got any pulses?
I'm not getting a pulse.
The patient has obvious fractures to both femurs. No other injuries. Over.
Go ahead and intubate him, hyperventilate and transport. Over.
Intubate and hyperventilate in transport. ETA 5 minutes. Over.
We'll be standing by to receive. Base out.
Hey, someone call security!
You see what's happening there? I've got an ambulance coming.
I don't want to be in here! I need some help in here! I'm fine!
Charge nurse and resuscitation team to room 2.
Okay.
Dispatch trauma team to the ED stat. We have a ranger coming in injured in a 30-foot fall off the tower. He's unconscious and intubated with bleeding from the right ear. He's got bilateral femur fractures. ETA is about 3 minutes. I've activated the trauma team.
Do you want me to call neurosurgery and ortho?
Not yet. Let's get some blood tubes and IV
Dr.
fluids.
Bridgeton, we've been asked to give consultants a heads up as soon as possible. I think we need to notify neurosurgery and ortho.
You're right. Go ahead and call. Let's get set up.
I'll get a traction set up.
Good. Sergeant Lindquist, you set up the monitor and have that ready when they bring him in.
Yes, ma'am, I'll get the monitor set up and ready.
Captain Toscano, notify CT that he's coming and send for blood.
Yes, doctor, I'm notifying neurosurgery, ortho, CT, and sending for blood.
24-year-old male took a 30-foot fall off the tower. He's unconscious with bruises on his head and bleeding from his right ear.
On my count then, ready. 1, 2, 3. Sergeant Lindquist, check his pulse.
Pulse, yes, ma'am.
Lieutenant Brooks, get me a blood pressure.
I'll get his BP, ma'am.
His breath sounds are decreased on the right. Let's get a chest tube in him. Dr. Andrews, you take care of that at 36 French on the right side.
Yes, ma'am.
Dr. Bridgeton, his BP is 120/74.
Ma'am, pulse is good. Rate is 115. He's on the monitor.
Captain Toscano, give him 25 grams of mannitol IV.
Yes, ma'am, 25 grams of mannitol IV. X-rays here.
Is CT ready?
They're ready and standing by.
Then let's get him over to CT for his head, and while we're there, let's scan his abdomen and pelvis. Thanks for a good job. I'll let you know what we find.
The white motorcycle versus a gray Sebring.
University, we're in around your facility. Single motorcycle, closet control, no helmet.
The University of Utah was the first Level 1 trauma center to be certified by the American College of Surgeons in the state of Utah. We admit more than 2,000 trauma patients per year and have a dedicated trauma surgeon and trauma response team in the hospital 24/7 to care for the injured patients and their families. Trauma care begins at the scene.
Hey Rob, we're almost there, okay? Hang in there.
With arrival of EMS personnel. To ensure appropriate deployment of resources within the hospital, we have developed specific criteria for trauma activation. There are 3 levels of trauma activation. This activation criteria is based on vital sign assessment, obvious injury, mechanism of injury, and special considerations such as use of anticoagulants or extremes in age. A level 1 activation indicates life-threatening injury. A level 1 activation will summon providers from trauma surgery, emergency medicine, anesthesia, orthopedics, neurosurgery, pharmacy, respiratory therapy, and social work to the ED. Additional blood is brought to the trauma operating room on hold in the event the patient requires immediate surgical care.
1029, go ahead, AirMed.
Combative, we electively intubated him.
During radio contact, it's important to quickly convey pertinent information about the patient and their injury, including the mechanism involved, vital signs, treatment given, and ETA. Before the patient arrives, the team conducts a trauma timeout, an important step in which the trauma team leader identifies team members and their roles, with assignments for specific procedures that might be required.
So if we need a chest tube on the right side, I'm going to have you do that, and you'll be responsible for the fast exam after the primary survey.
At this time, the team leader will share any updated information and details about the patient's mechanism, vital signs, interventions, and identified injuries. Necessary equipment for prospective procedures is made available. For all Trauma 1 activations, a chest tube tray and MAC lines are to be placed on either side of the trauma bay so that they are readily available. The rapid fluid infuser is primed for use. The team members are in the room and their positions are: the trauma team leader is positioned at the foot of the bed. This is the person in charge and to whom you will give report. The airway provider is at the head of the bed. This person is responsible for assessing the airway and establishing an airway as needed. They are also responsible for assessing the GCS and performing the head exam. Examiner 1, at the patient's right, is responsible for the initial airway, breathing, and circulatory assessment, and performs the fast ultrasound exam of the abdomen to assess for internal hemorrhage. Examiner 2, at the patient's left, assists in exposing the patient and performs the secondary survey. The trauma nurse, at the patient's left, obtains the first manual blood pressure upon arrival, places monitors, and assists with IV access. The trauma scribe, behind the team leader, records events, orders, physical findings, and patient response to treatment. Other people in the room will be the trauma EMT, a lab tech, and a pharmacist. This is the core group of providers who will be in the same role each time for every trauma patient. When the patient arrives in the trauma bay, team members are already positioned, have completed their timeout, and prepared to begin the trauma resuscitation based on current ATLS guidelines.
Trauma 1 has arrived.
Trauma arrival is announced over the overhead, and the room should be quiet and free of distraction for the subsequent steps. During the time the patient is undergoing the primary assessment, the EMS personnel can give a brief summary to the ED attending of interventions performed since their last communication. They can also supply any images on disk if the patient came from another hospital so that they can be uploaded.
Ready to move? 1, 2, 3.
The patient is brought over to the trauma bed from the stretcher where Examiner 1 will perform the initial assessment of the airway, breathing, and circulation. If life-threatening emergencies are identified during this assessment, treatment is initiated immediately. The trauma nurse gets an initial manual blood pressure reading, which is called out to the trauma team.
80/50.
After life-saving maneuvers are initiated, a report is then provided by EMS. The trauma leader will request a formal report that's given to the trauma team by the EMS.
Okay, let's go ahead and get a report.
This is a 37-year-old male who was involved in a motorcycle crash, no helmet.
Our newly developed EMS report template can be used as a guide. As report is taken, several processes of patient assessment begin to occur. IV access is confirmed and possibly new peripheral access is established. The patient is exposed so that injuries can be identified and assessments can be made. fast exam is performed. Examiner 1 begins the fast exam. Pelvis is assessed for fracture and gross extremity deformities are noted. Peripheral pulses are checked in all extremities. Examiner 2 begins to perform the secondary survey with assessment of anterior chest, abdomen, and pelvis, as well as extremities.
Okay, 1, 2, 3.
Once these steps are complete, the patient is rolled to access posterior surfaces and palpate spine, and the spine board is removed. It is our goal to have a defined plan for the trauma patient in less than 15 minutes. Decisions must be made to go to the CT scanner, the operating room, the ICU, or the ED observation unit.